Good evening. I'm Liz Roberts-Kirchhoff, and I want to welcome you to the University of Detroit Mercy. And we're happy to host this health lecture series with the Michigan State University College of Human Medicine. And I'm going to turn it over to Arlene Daly, who is going to introduce our speaker for this evening.
Dr. Liz, thank you. Thank you for joining us this evening. It is an honor and a privilege to introduce Dr. Leonard Fleck. He is a distinguished professor with the College of Human Medicine and the Center of Bioethics and Social Justice. So without further ado, thank you this evening.
Yeah. Good evening, everyone. I'm very pleased to be here with all of you. This is going to be kind of a quick tour having to do with precision medicine and some of the problems of healthcare justice that are associated with precision medicine. And I'll start off by saying I don't have any conflicts of interest. That's one of the normal things you're supposed to say, except for that book over there. So where are we going to be going this evening, and how are we going to get there? You have that up on the slide. So the first thing I want to talk about is something called the just caring problem. And the just caring problem goes like this. What does it mean to be a just and caring society when we have only limited resources, money, and virtually unlimited healthcare needs? The reason we have virtually unlimited healthcare needs is because what we identify as a healthcare need is something that is related very often to emerging medical technology, such as everything going on in precision medicine. And though as new technologies come on board, we in effect say that generates more in the way of healthcare needs. So if I were to ask everybody how many people in the United States needed bypass surgery in, say, 1970, it's really easy to answer that question. Nobody, because it had barely been invented. But last year we did about 450,000 bypasses in the United States at a cost of about $50,000 or $60,000 per bypass. And you multiply that by all the other different kind of emerging technologies, you have the beginning of understanding the just caring problem. And then we're going to ask ourselves, what is precision medicine? And we'll talk about a description of what exactly is going on with precision medicine. And then one of the things I have to shake your faith on is the fact that precision medicine is probably misnamed, that precision medicine has a considerable amount of imprecision and uncertainty associated with it, which is going to become really clear as this presentation goes on. And then in the title slide for this session, I asked the question whether human life is priceless. And if you think human life is priceless, then who's paying for that? And of course, the question I ask for myself is there a senior discount? So that seems like a reasonable question to ask. When we talk about the just caring problem, one of the implications of the just caring problem is there are limits to what we can spend or are willing to spend on meeting healthcare needs. And the consequence of that is that healthcare rationing, denying individuals what is clearly needed healthcare, sometimes needed for life itself, is one of the consequences of the just caring problem and taking it seriously. And then finally, there's the question of, is it possible in a liberal, pluralistic, democratic society to talk about the various conflicts that arise in connection with having to make these kinds of rationing decisions? Can we do that in a reasonable way? It's hard to give that question a positive answer, I realize, in the current political environment, but I'm a little bit more of an optimist, and so we'll talk about that. So I've already mentioned to you what the just caring problem is. Its implication is there are limits on what we're willing to spend on meeting healthcare needs. We all would like to believe that it's somebody else who's going to be paying for that my healthcare needs and whatever is needed in order to address them. But the fact of the matter is, collectively, we're all responsible in one way or another for paying the cost of healthcare, of meeting the healthcare needs in our society. And so the problem is, what are we really willing to spend in order to meet all the needs, healthcare needs in our society, not to mention everything else in the way of social needs that are also that need to be addressed and that command some level of social resources. So given the just caring problem, one of the things you need to understand, as I mentioned before, is that it's all these emerging technologies that are the primary driving factor that is pushing up overall healthcare costs. I'm going to give you some statistics in just a bit. One of the points that I make in my most recent book is that the problems, the ethics issues that I'll be identifying tonight are what some researchers refer to as wicked problems. And by a wicked problem, they mean a problem that it seems no matter how we try to address it, no matter how much thought and energy and effort goes into trying to address the problem, whatever solution we come up with seems to generate even more problems or problems that are just as complex as the one that we're trying to address. And we'll see that there are numerous wicked problems that are associated with precision medicine. So you might ask, with regard to the issue of whether or not human life is priceless, how I began to think about that. And the short answer is this. Way back in like about 1976 or so, I was reading a story in Parade magazine, a very formidable piece of, I guess, journalism. And in the story, it pointed out that every year in the United States, there are 50 Americans who die as a result of bridge collapses. Wow. And so somebody went to members of Congress and said, what are you going to do about this? And of course, members of Congress said, well, we're not just going to ignore that problem. We're going to throw $26 billion at that problem and try to fix all the bridges that are collapsing in the US to prevent that loss of 50 lives. Well, of course, if you divide 50 lives, even over some number of years, into $26 billion, that's a very high price for each of those lives that are saved. And then I thought a little bit more about it. And I thought, you know what? Another issue would be, why would we stop the bridge collapses? There's only 50 lives per year that are lost there. At grade level railroad crossings, there are 2,000 lives that are lost each year in the United States. And why are 2,000 lives lost at grade level railroad crossings? Because people are foolish enough to think that they can beat the train. They go around the crossing gates and so on. And it turns out it's a tie rather than a win. And a tie is as bad as a loss at that point. And so in order to address that problem today, we would have to you can address it. You separate all the grade level railroad crossings. You build overpasses and underpasses. That's about a $200 or $300 billion project that we'd have to undertake to say, are we ethically obligated as a just and caring society to build all those overpasses and underpasses? That's the problem of pricing human life. And obviously, as a society, we're not willing to pay the additional taxes that would be necessary to accomplish that. And so what that means is that, as a matter of fact, we are not inclined to believe that human life is really priceless, unless it's our own life. That's a different story, it seems. So again, just to call your attention to some statistics, in 2022 in the US, we spent $4.4 trillion on healthcare. In 1960, we spent, in 2022, that represented about 18% of our gross domestic product. In 1960, we spent $26 billion on healthcare, or it would be $240 billion if you translated it into contemporary dollars. That was only 5.2% of our gross domestic product. So you can see that the fraction of our gross domestic product, total economic activity in our society, we have almost quadrupled the amount of that money that goes into the healthcare system as opposed to anything else going on in our economy. The projection to 2031 on the current trend line is that it will be spending $7.2 trillion at that time, or about 20% of what's expected to be our gross domestic product then. Another statistic I want you to be mindful of is that on the Medicare program, healthcare for the elderly, we have roughly 14% of our population is over age 65, so they're eligible for Medicare. Today, that's about 50 or 55 million individuals. We're halfway through the baby boom generation, and so by 2030, it's going to be about 80 million individuals over age 65. What's significant about Medicare is that the 14% of the population that is over age 65 right now actually consumes 37% of that $4.4 trillion, which is about 1.4 trillion. So you can imagine where we'll be in 2030 in terms of expenditures. And This year, Medicare will spend slightly more than $1 trillion. And the projections over 10 years are that Medicare will be spending about $12.3 trillion. And so that gives you a sense of where some of the economic issues are that are facing our society. We're going to be focusing a lot on cancer. That's right now, that's where precision medicine mostly is. And so some statistics with regard to cancer is that about 1.8 million Americans are going to be diagnosed with cancer this year. 610,000 Americans are going to die of cancer. Cancer is largely a disease of older individuals. 87% of individuals who are diagnosed with cancer and die of cancer are over the age of 50. And that'll be a number I want you to keep in mind for later in the slides. And most cancers are treatable if they're caught early enough. And so roughly 55% of cancers are non-fatal. And the cost of cancer treatment is extraordinarily high and growing very rapidly because of the various drugs that constitute what we call precision medicine, what are called the targeted cancer therapies and the immunotherapies. We're talking about a problem of healthcare justice. That's the ethics issues that's at stake here. And so the basic question is, if we don't have enough money, if we're not willing to spend enough money to cover all the healthcare needs that are out there, how in the world should we figure out which healthcare needs are of higher priority and which are of lower priority? And so is it the case that cancer needs and the needs of patients with metastatic cancer, they should be top priority, or patients with heart disease or lung disease or liver disease or dementia or HIV and so on? And so you've got lots and lots of healthcare needs, and they're radically different from one another. And so the heterogeneity of healthcare needs makes the issue of figuring out how you make comparisons and appropriate allocations of healthcare resources all the more difficult. We have different theories of justice that we operate with. At least philosophers talk about theories of justice, but these are not things that philosophers have made up. What philosophers talk about with regard to different conceptions of justice are things that we can all identify with. So you've got what's called a utilitarian theory, which says that if we've got limited resources, then we want to spend those resources in such a way as to get the most health good possible for each dollar that's spent. But a consequence of taking that seriously is that individuals who have very, very costly health needs, who are unlikely to benefit very much from putting lots and lots of money into them, are not going to have their needs met. But they are among those who are the least well off. And so the prioritarian says, you should, from the point of view of a just and caring society, you ought to devote the most in the way of resources to for those who are medically least well off. And how are we going to identify who counts as being among the medically least well off? Individuals who are faced with a terminal illness, well, that would be one starting point, except there are lots and lots of terminal illness, or what we call terminal illnesses, most of which will in fact end up being terminal, but others of which, if you spend enough money and make enough in the way of health resource allocation, will end up at least not being terminal at that particular point in time. And so then there are other theories there's the luck egalitarian view, which basically says, everyone is entitled to whatever they need in the way of access to effective healthcare. But if individuals are in one way or another responsible for their healthcare needs, if they've made some really bad choices, if they've been smoking cigarettes for the past 40 years to 2 packs a week or 2 packs a day, or if they've been out sunning themselves every summer and exposing themselves to melanoma, or if they have, and you go through a whole laundry list of what you would think of as bad health behaviors, well, they should take responsibility for paying the cost of their own health needs. I, who am much more attentive to my healthcare needs and protecting my health, I shouldn't have to pay for meeting their healthcare needs. That's the perspective of somebody who would be called a luck egalitarian. If I get sick, it's just bad luck. It's not my fault. Okay, that's the issue that's going on there. And so, of course, cancer, some cancers, lung cancer, mostly has to do with smoking, melanoma, mostly with sun worshiping, except, of course, then you've got migrant farm workers who have to work in the fields under the sun and who are vulnerable to melanoma, not to mention all the chemicals that they're exposed to. Well, you got to separate those folks out. And so just to give you a sense of what some of these problems are. So what's the idea behind precision medicine? The basic idea behind precision medicine is that we have to get away from the idea that one size fits all, that there is this one drug that is a cancer drug, or this is a one drug for the flu, or one drug for pneumonia. And everybody who has something called the flu or the pneumonia or cancer, they get that drug. And so the recognition, so far as precision medicine goes, as we'll see, is that cancer is not one disease. Cancer is not just associated with a particular organ of the body. That's the wrong way to think about it. Cancer is now recognized to be describable and therapeutically responsive to in terms of the genetic features of a cancer. And so there are now we have to say there are hundreds of kinds of cancers that are out there that we have to identify by the genetic features of that cancer, because it's those genetic features that are going to determine which particular targeted therapy will be used to deal with it. And so if precision medicine is so precise and it has so many beneficial effects for everybody concerned, if that's what the goal of precision medicine is, then why in the world would there be an ethics problem? It just doesn't sound like that should make sense. So here's the cover of Time magazine from the year 2000. Imatinib would be the first drug for ALL back in 2000, which was a therapeutic success. And it is a therapeutic success today as well. But that's an illusion, because what researchers came to believe was that as we find these other targeted therapies, they are going to have the same kind of success that imatinib did. So imatinib has resulted in individuals getting from 7 to 10 to 12 extra years of life after a cancer diagnosis. But in terms of all the other targeted cancer therapies that are out there, in general, the vast majority of patients will gain extra months of life from having access to these drugs, and these drugs are extraordinarily expensive. And so it doesn't look like this is a very good buy. When I say extraordinarily expensive, what we're talking typically about is our costs in the vicinity of $150,000 per year for one of these drugs. But in some cases, the cost for some of these, the immunotherapies, will go to $475,000 at the front end. So we've got right now about 150 cancer drugs that have been developed since the year 2000. And I've already called your attention to the high cost of some of these. But the median gains in life expectancy for most patients are measurable in months, not years. But when I say most, I do mean just most. So there's a percentage of patients in say the 10%, 15% range who will gain 1 or 2 extra years of life. And we don't know who they are before the fact. So that's part of what creates the social, ethical, economic problem for us. And there's a really tiny number of patients who are what we call super responders, who end up getting 7, 8, 9, 10 extra years of life, while everybody else has only gotten months or a year or two at most from having access to these drugs. And so just to give you a picture of what we're talking about here, there on the slide, I'm not going to go through this, but you can see on the slide the names of some of these drugs that we're talking about. You're seeing either the annual cost or the monthly cost of these drugs. And so you get a sense of what it is that we're talking about. Here's another slide just to show you how many of them there are and how costly they are. And they're all associated with treating very different cancers. And one of the problems with thinking more carefully and critically about precision medicine has to do with the tendency of researchers and the drug makers themselves to be overly optimistic about how successful, how therapeutic these particular drugs are. And so a recent headline from 2022 in the New York Times is breast cancer drug trials result in unheard of survival. Whoa. And so what exactly are they talking about here? Well, it turns out in patients who took what's a drug called trastuzumab deruxtecan, tumors stopped growing for about 10 months as compared with 5 months for standard chemotherapy. The patients with the experimental drug survived 23.9 months as compared to 16.8 months. So that's a difference of the gain in life expectancy relative to current treatment with your typical cancer drugs is 7 months. And so that is an unheard of survival. I mean, that just seems like an exaggeration. The cost of this drug is $14,000 every 3 weeks. That works out to $238,000 per year. Here's a picture of what we're talking about when we talk about the different molecular makeup, the mutations that drive different cancers. So on the slide, you see over on the left side there, lung adenocarcinoma, and below that you see some of the what they call driver mutations that are responsible for helping to grow particular cancers. You have KRAS for 25% of lung adenocarcinoma. KRAS is the driver, but then you go down to NRAS or ROS or RET. Now you're talking about 1% of the cancers are like that. So for each of those, and that's just a possible list, this is just a partial list, we would need a different drug to treat each of those different mutations. Okay, and so that's why, those mutations are the targets of the targeted cancer therapies. And then you see for lung squamous cancer and breast cancer, there are these other different mutations. Here's colorectal cancer, melanoma, head and neck cancers, and so on. And so this is just a list of the more common cancers and what the different molecular characteristics are of those cancers. So I want you to pay attention to the fact that for each of these cancers, there's only a relatively small number of patients who can be treated at very high cost with these targeted therapies. And so if you think of any of the standard drugs that are out there for treating heart failure, you have literally 10 million, 20 million patients in any given year who are on those drugs. That's a huge population. And so the cost of those drugs typically is relatively low. But here, what we're typically talking about are relatively small population with a particular variant of one of these cancers, and who need a drug that is only going to treat several thousand patients in any given year, as opposed to hundreds of thousands of patients. And so, in one case here, for a non-cancer thing, we're talking about ALS, and there's a drug called tofersen. It's of use for 2% of patients who have ALS, who have the mutation called the SOD1 gene. And the cost of being treated with that drug is $375,000 per year. And so there's a total of only 2% of patients with ALS for whom that drug is, in fact, something that will have some degree of therapeutic benefit. The wicked question down there is, are we ethically obligated to find out all the different genetic variants of ALS for which we ought to invest research dollars in order to find drugs that will treat the other 98%? Now, we have what I refer to here as a number of inchoate moral intuitions that pull us in one direction or another. From my point of view, I argue most of these moral intuitions are going to distract us from addressing the problem of healthcare justice in our society. So we have something called the rule of rescue. And the rule of rescue makes sense, it makes some sense when we're talking about some individual who has done something really, really crazy. They decided some 17-year-old wants to sail a 15-foot sailboat across the Atlantic. And all of a sudden, in the middle of the Atlantic, there are these 30-foot waves, and they send out a help signal, help, help, help. And somebody picks it up, and we're going to spend millions of dollars to rescue them. And we feel ethically obligated to do just that. We can afford to do that because those instances are relatively rare occurrences overall in society. But cancer and heart disease and terminal illnesses of all kinds, those are common events. And so what does the rule of rescue require of us in those situations? Are we supposed to spend unlimited sums of money to rescue somebody from their cancer, their heart disease, their dementia, whatever? We're talking, a lot of times we'll say, if we're talking about a last chance therapy, then that is somebody doesn't have any other chance, there's nothing else we can offer them, are we then ethically obligated to provide them with one of these very costly drugs? Because that's the only thing that might do some good. Are we ethically obligated, if we believe that human life is really priceless, to spend unlimited sums of money in order to prolong the lives of individuals who have metastatic cancer? Because that's mostly what we're talking about here. We're talking about metastatic disease, which for all practical purposes is a terminal kind of diagnosis. So here's our first wicked problem, the so-called ragged edge. There is no sharp line that distinguishes responders to one of these drugs from non-responders. And so the issue is, what are we supposed to do? Should we arbitrarily draw a line somewhere and say, if we believe that you're not going to survive more than 6 extra months, then we're not going to provide you with the drug. If we have reason to believe that you're going to survive more than 6 extra months, then we'll provide you with the drug at social expense or something. And so how do we go about justly creating a bright line anywhere? And then this is just one example of that. An egalitarian, somebody who says everybody should be treated the same when it comes to meeting healthcare needs. John Harris is an egalitarian philosopher, and he writes, quote, "So long as people want to live out the rest of their lives, however long this may be or looks like being, then they should be given the best chance we can give them of doing so. And we should not choose between such people on any other grounds, but treat each as an equal." So in effect, that says we shouldn't bother trying to figure out who is going to gain the most in the way of extra months, extra years of life. We should simply accept the fact that if somebody has this cancer with this genetic mutation, and we have this drug, no matter what it costs, that will likely yield some good, then we have to provide it to them. That's not something that's ultimately affordable. And so we have to ask, well, would it be unjust to deny a whole cohort of patients access to these drugs at social expense? That's one way of dealing with the ragged edge problem. And in fact, saying, well, if we can't afford to provide the drug for everybody in that category, then we won't provide it for anybody at all. That doesn't strike most people as being acceptable. And then what if we knew that when we were tempted with that idea that, well, 10% of these patients, we're going to get 2 extra years of life. We might be comfortable enough if all we're denying individuals is 3 to 6 extra months of life, but 2 extra years, well, that's a little more problematic. And then we go to another wicked question is, one of the kinds of research that's going on now is research looking for biomarkers that are predictive of what we can expect in the way of a therapeutic effect for this patient if we give them this drug. And the problem is, quote, "But developing such a test for whatever kind of a biomarker we're looking for has proved tricky so far for ethical as well as scientific reasons. Some doctors said it would be unfair to withhold the new drugs from patients based on a test if there were even a slight chance that the drug would help them." Okay, and so this becomes part of the problem we're faced with. There's a link here to a television ad for Optivo. How many of you have seen a television ad for the drug Optivo, the volume ad? Good. Okay, and so what for the rest of you, what the ad shows in 30-foot high letters, either on a building or on a cliff in a nice setting, are the words, "A chance to live longer." And you see all these happy people running around in the streets or on the beach or wherever, the drug treats non-small cell lung cancer. They obviously, if they had metastatic non-small cell lung cancer, they wouldn't be running around like that. But nevertheless, the message to the public is, here is something that will give you a chance to live longer. The ad doesn't say 3 extra months, which is what most of the research would say for most patients who got the drug. But nevertheless, it is a seductive message, and there are about 6 variants of that particular ad that are on TV nowadays. For non-small cell lung cancer, there are about 160,000 of those deaths right now in the US each year. And if the cost of treating those patients, if they were given a $100,000 drug, would be about 16 billion. The drugs now are 150,000, and so the real cost is probably closer to 24 billion. And it all depends on and it will depend upon which of the mutations those patients have. So what is it that gets in the way of the effectiveness of these drugs? The basic problem is that resistance develops to these drugs for all kinds of reasons. And so on the slide here, I point out that the drugs, some of the targeted therapies that are most common are the TKIs, the tyrosine kinase inhibitors. And what happens is that the drug is initially very effective. It's targeting the primary driver of that cancer, okay? And in fact, it kills most of the cells that contain the primary driver of that cancer. But then you have what emerges after a few months is another one of mutation that becomes, in kind of Darwinian fashion, the new primary driver of the cancer against which that drug is no longer effective. So then you have to switch drugs, and then yet another driver emerges for the cancer. And so you get into the third and fourth generation of these drugs as you try to stay ahead of whatever the emerging problem is. And so what you find, again, the main point in this slide here is that mutations continue to evolve in response to our use of these particular drugs, that is, resistance comes about. And then we have to try another drug, which may or may not work for very long. But there is a limit to what we can do there. The other thing that is the major problem with regard to cancer is the problem of genetic heterogeneity. If you were to look at all the all the cells in your body, what you would find is that every one of those cells is a carbon copy of all the other cells in your body. But with cancer, the problem is that cancer cells are genetically heterogeneous. They have many, 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 literally hundreds of mutations that evolve that are part of that cancer. And as the cancer evolves, those genetic mutations become even more common. And because those genetic mutations are there, they're there not in each and every tumor, because in each and every tumor, there can be different drivers of that particular cancer, which is why what we've found with the targeted therapies is that none of the therapies are typically more effective in terms of slowing tumor growth than over a period of some number of months, but not years. So the idea is that if you have simple clonal cancers with low levels of genetic instability, then you're going to get a long-lasting response. But if you've got tumors that have lots and lots of genetic heterogeneity, the therapeutic response is going to be relatively short. So as I was saying before, and as these two researchers conclude, the challenge of tumor drug resistance therefore represents a pervasive barrier that confounds the ultimate goal of cure or long-term control of metastatic cancer. So what kind of strategy can you use by way of addressing that problem? Well, one of the strategies that has been proposed is that we should follow the AIDS strategy. So the AIDS strategy is we use multiple drugs in combination to contain, not defeat, HIV. And that basically has been very successful. Patients with HIV can now expect to live 20 or 30 years or more beyond initial infection with the help of these drugs. The problem with the cancer drugs is that in putting these drugs together, you increase dramatically the deleterious side effects that are associated with the drugs. And so in some cases, the therapy is worse than the disease process. In either case, if you're using multiple $150,000 drugs, the cost of the therapy escalates dramatically as well. And so another cover from Time magazine, How to Cure Cancer. We really don't have any idea at this point. It's more than optimistic to say that we're getting closer and closer to curing cancer. what we're getting closer and closer to is understanding the complexity of the disease process and the difficulty of finding some one thing that if you find that one thing, you have access to controlling any kind of cancer at all that might be out there. So this is the problem of clinical heterogeneity. And then I bring you back to the problem of healthcare justice. Which of these different conceptions of justice should we think of as being most relevant to determining how should we allocate access to these different targeted cancer therapies? And that is, how should we address the various wicked problems that I'm going to be calling to your attention? The view of the libertarians, which I hadn't mentioned before, is that you have a right to a therapy if you can pay for it. If you're very well insured and your insurance company wants to pay for it, okay. If you're not well insured, if you don't have a lot of money in your savings account, then you don't have any just claim to it. That would not strike me as being a very just approach to addressing healthcare needs in our society. And part of the reason for that is, if you think about it, the healthcare system we have today is a system that has been publicly funded in terms of training all physicians, nurses, other health professionals, largely at social expense, in terms of all the research that has generated the basic knowledge that pharmaceutical companies then use to actually develop these different drugs, plus all the other kind of technological research, building hospitals and clinics and so on that have been publicly funded. So what we might imagine is that if in fact the use of multiple cancer drugs together in some circumstances would work in terms of prolonging life for as much theoretically, this is theory, as 5 years, we would say, wow, that would be great. We would feel ethically obligated to do that. But the problem is then from 1 year to the next, you're increasing the size of the cohort of very costly individuals whose lives you're sustaining. And so you can imagine, given 600,000 cancer deaths each year in the United States, if in fact we had something therapeutic for all the different cancers that those 600,000 people had, we'd be talking about over a 5-year period at year 5, having to spend $300–400 billion per year for treating just those metastatic cancer patients, nothing else in our society. And so we have to ask whether we are ethically obligated to do just that. So we want to try to make some comparisons. Where else are we spending lots of money as a way of trying to get a handle on how we figure out what is the appropriate just response to dealing with the complexity of issues related to precision medicine. And so we point out we're paying currently about $88,000 per year for dialysis for approximately 570,000 such patients. On average, patients on dialysis will survive 5 to 7 years, some for longer than that. But that means that the aggregated cost per person of treating them is going to be between $650,000 and $1.4 million. And we accept that. I mean, that's what we do today. Now, the one thing that is unusual with regard to dialysis is that back in the early 1970s, we passed something called the End-Stage Renal Disease Amendments to the Medicare program. Those amendments said Medicare is going to pay for dialysis and/or kidney transplants for anybody who has end-stage renal disease. Doesn't matter whether you're insured, uninsured, working, not working, all that's irrelevant. If you have end-stage renal disease, we will use public funds to pay for whatever you need in the way of medical care to address that issue. That sounds like a very noble and compassionate thing. It was, in effect, universal health insurance for anybody who had end-stage renal disease. Of course, the ethics issue that raises is, well, my problem is I've got a failing heart and I need a heart transplant. Who's going to pay for that? Because my insurer says they won't pay for it. Or they won't pay for my pancreatic transplant, or you go on. So that's the kind of issue of healthcare justice that in part we created by putting in place the end-stage renal disease. And then the other kind of things I can point out, right now we pay about $250,000 to provide individuals with end-stage heart failure, an LVAD, a left ventricular assist device. We're working on developing artificial hearts that will cost about $500,000 to implant and so on. For HIV positive patients, we're on quadruple therapy. The cost is about $35,000 per patient. For cystic fibrosis patients, now we have these drugs, ivacaftor and lumacaftor. The cost of those drugs is $310,000 per year per patient. And then we've got some of these gene therapies like Zolgensma, the cost for spinal muscular atrophy that has costs of $2.1 million. And apparently we're willing to pay that cost. And so advocates for patients with metastatic disease say, well, hey, if you're paying all that money for all these other patients, why can't you pay lots of money for us as well? So there are a lot of morally reasonable paths forward. We're looking, so I mentioned before, we're trying to find biomarkers that say, these are individuals who are going to do really well, relatively well with this drug, and these are individuals who aren't going to do so well. What are the problems with looking for biomarkers like that? Well, I'll give you one kind of example. Instead of using targeted cancer therapies, the other big strategy are what are called the immunotherapies. That is modifying in one way or the other the immune system to make it better at attacking cancer cells. And one of the kinds of cancer therapies we use is something called CAR T-cell therapy, which is a very, very complex process for re-engineering the T cells, your T cells, to better fight your cancer, okay? And the front end cost of CAR T-cell therapy is $475,000, unlike a monthly cost, okay? And so the issue is this. What we know right now is that about 30% of patients with metastatic cancer who are given, and these are blood cancers typically, who are given CAR T-cell therapy, 30% of them will die in less than a year after being given the therapy. The rest, most of the rest will gain somewhere between 1 to 4 extra years of life. And then those CAR T cells kind of poop out. They don't work any longer. And so the issue is, would you, not knowing what your own future health needs might be, would you endorse the idea of identifying a biomarker that would say, this patient will, with 90% confidence, not survive another year if we provide them with CAR T-cell therapy? Would you endorse that? And so this is something you might wish to discuss in the time we've set aside for questions and so on. So here we're going to go into the ethical weeds, and got some interesting weeds there I discovered. And then I mentioned before the super responder patients. We actually have a faculty member in the College of Human Medicine who was diagnosed with a stomach cancer, was told he had about 6 months to live. Except they did a genetic analysis of his cancer, and it's HER2 positive. We give you trastuzumab for that. And so they put him on trastuzumab. He's alive today, 11 years later. But every 3 weeks, he has to get an infusion of trastuzumab, and at a cost of $17,000 per infusion. Well, that has added up to about $1.5 million over those 11 years. The reason why he did so well, in all likelihood, is that the genetic features of his cancer, for whatever reason, were very stable, or it was treated early enough when the cancer was still very stable. So trastuzumab works, and it worked for him. He was part of a whole cohort of other patients who were just like him, except they all died in less than 2 years. So you have these very high front-end costs that I mentioned there. And let's see, I'm going to just jump way ahead here. And this is going to be the last point I want to make, because here's one of the things that we're faced with, the problem of what's called precision health. And the issue is a book by oncologist Azra Raza, who titled The First Cell and the Human Costs of Pursuing Cancer to the Last. And she argues that we should forget about all the money we're spending, tens of billions of dollars on these targeted cancer therapies. That money should be used instead at the front end to try to find ways of defeating cancer as early as possible. And how are we going to do that? This is what is being advertised right now by a company called Grail, who have a screening test for cancer called Gallery, okay? And this test is capable of identifying more than 50 cancers with a simple blood test, okay? That has to be analyzed by PCR. And the cost of doing that is $950. Grail wants every individual in the United States over the age of 50 to have that test once a year. Okay. The cost of doing that would be over $100 billion per year. Is that a good buy? Here's what you get. Some of you are familiar with the ideas of specificity sensitivity. Well, if you have a stage 1 cancer, that test has a sensitivity of 16.8%. That means it misses 83% of the cancers at stage 1. At stage 2, 40%. So it misses 60% of them. Stage 3 is at 90%. That's pretty good. Or I'm sorry, that's stage 4, 77% of stage 3. So would you endorse the idea of spending $100 billion a year? Well, what is Grail doing? If I ask each of you whether you want to spend that money, you might say, I don't think so. But Grail wants Medicare to underwrite those costs. And there's a bill in Congress right now that would that's intended to underwrite the costs of access to that test. For at least for Medicare patients, that would add $55 billion each year to the cost of Medicare, which hit the $1 trillion mark earlier this year. And so we have to ask this question, whether or not this represents a good use of limited healthcare dollars. Is this something you would endorse? And one of the things I can tell you is that what Grail claims is that if we followed their research, they have not done very much in the way of true empirical research. They've done all kinds of other analysis, hypothetical analysis. If we did that, they claim we would save 160,000 lives per year. That requires the most optimistic imaginable assumptions to achieve that result. It's more realistic to say that if everybody, 110 million Americans took that test every year, in theory, we could save 36,000 lives per year. But wait, that assumes that those 36,000 individuals were very well insured and could afford the biopsies and the cost of the therapy itself. So if they're not, so you have to reduce by a third, at least, that 36,000 number. And so 24,000 is still an optimistic number to believe that that would be the result of spending the $100 billion. And I ask, is that how you would want to spend that $100 billion? And so we're going to just stop right there because there's all kinds of other issues that can be raised here. But I want to give all of you a chance to ask questions, which I won't be able to do if I just keep yammering on. And so I have polling items there and references and so on. And so I want to give all of you a chance to ask any questions you might have, either here in person or else if you're in the webinar and you want to type in a question, they got to type in a question. We have somebody here who will read those questions to me and I'll be happy to respond. Have I?
Well, I was thinking on the other side of this about the potential value of developing types of research for drugs that could then be marketed so as to become cheaper, like with the mRNA vaccine that started out earlier and then turned out to be useful when COVID came along. And since we had the technique developed, it was easy to develop a vaccine. What about the added benefit that we might get from that?
Okay, so the question is whether or not there would be a way of developing less expensive drugs that would mimic what the very expensive targeted therapies are doing now. Is that the gist of your question?
Well, once those techniques were perfected for categories of drugs, for development categories.
Oh, the most common categories have to do right now with these tyrosine kinase inhibitors and the monoclonal antibodies of various kinds. Those are the two big categories of drugs. Plus there are what are called the third category would be the checkpoint inhibitors. The checkpoint inhibitors are a form of immunotherapy, and those would be the three biggest categories of cancer drugs. But you got to remember that each one of those drugs is developed to be responsive to some genetic feature of the cancer itself. And so what that means is that, as I noted earlier, it's relatively small numbers of individuals who in fact can be treated somewhat marginally effectively with those drugs. And so from the point of view of drug companies, that's a part of the reason why they price the drugs as high as they do, that they have very, very high costs associated with developing the drugs. And the drugs are often given by infusion. So you've got additional costs associated with doing that. And because you've got the cost of professional services that are provided at an infusion center. So there's not a lot of opportunities and nor is there a lot of motivation for finding generic drugs or that would copy in some way the effective mechanism of the drugs that are now under patent. So the short answer to your question is, at least from the point of where we are right now, we will continue to see these very expensive drugs developed in relationship to the genetic features of these different cancers, or in some cases going outside of cancer. Okay. So who should pay for all of this? Here to finish up, what the last point I was making with regard to that Gallery test. Okay, that cost $950. How many of you would say there should be no social funding of that test? Instead, it's up to each. If you want the test for yourself, you just pay out of pocket $950 every year, or as often as you want the test. Would that be good enough? Or alternatively, I mean, because you have to look at what's going on here. I mean, 90% of cancers are not hereditary. Okay, only 10% of cancers, like Lynch syndrome, you have a familial history that can identify it, and with some breast cancers and so on, there's a familial history. So about 10% of cancers are like that. But for the vast majority of cancers, they seem to arise spontaneously. And in fact, everybody in this room, not to scare anybody, but probably everybody in this room has some cancer cells in them right now. But it's okay, because I know you don't want to die. Of course you don't want to die, but you don't have to worry, because most of us have really effective immune systems that are just wiping out those cancer cells as they appear, because they're oddballs. And the immune system says you don't deserve to live, so we kill those cancer cells. But part of the reason why cancer is more disease of the elderly than the non-elderly is because our immune systems do wear out a bit after they become less effective over time. And so our immune systems start missing some of those cancer cells, and they settle in somewhere and they begin to propagate themselves. And then we have a real cancer to deal with, okay? So you could say, if you wanted, with regard to the Gallery test, that it should be available at social expense, Medicare, private health insurance, for individuals whose cancer can be associated with a family history of some kind. How many of you would buy that idea? Say, that does not sound unreasonable. Okay. Yeah. How many of you would say, no, I like Gallery's idea, I like Grail's idea of having Medicare underwrite the costs for One head is shaking, no, no, no. What are the rest of your heads shaking? You're a no. How many of you are inclined to say, yeah, I like the idea of having society, in quotes, pay for these tests for anybody who wants one as a screening test for cancer?
It's only 50 cancers though, and there's hundreds.
Yeah.
I think also that that's using a portion of our healthcare dollars for that. And the people who are gonna benefit probably are gonna be a small portion of the people that can afford these hundred. So what are we not paying for everybody else? When we like.
That would be the healthcare justice question. Is there a better use economically and ethically for something like that $100 billion than spending it on a test like the Gallery test? What the Gallery, in any given year, if you take a population of, say, 100,000 individuals over the age of 50, then 99,000 of them would get back as a result, you don't have cancer. And 1% would get back a result that says there's a cancer signal we have detected. Half of those would be false positive signals. But it would take 162 days of all kinds of more invasive technology to assure you that this was a false positive cancer, and a cost of about $5,000. Okay, so those are the outcomes of that particular bit of technology. And this is all, you can see all of this as part of what precision medicine is all about. I don't want to yammer on here too long, so let me give you a chance. Anybody else have other questions that you wish to ask? Anything coming up from yeah. Oh, does the existence of that technology, would it lead to higher rates of non-compliance among patients? That is, and I take it what you mean is something like this, that, hey, if I can smoke and then if I end up with cancer, take this drug that will cure me of the results of my smoking. You could have a result like that. That could happen, where yeah, you could end up with a result like that. I can end up with a great suntan that everybody will admire, and if I happen to end up with some melanoma, we have a drug that can treat that melanoma, and so I can continue to look great in the summertime with my tan. And I suppose there's some number of people who would feel exactly like that. Yeah. A quick example might be, we have lots of stuff that we can do now for individuals with type 2 diabetes. Okay, the drugs that are also used for weight loss. Yeah. But and the thing is that if we can treat the results of type 2 diabetes, then I don't really have to worry about my love for carbohydrates and candy and sweets and anything else that may contribute to the emergence of type 2 diabetes. So that would be an example of where stuff like that would happen. Yeah. Do you have another question? Nope. Nope. Okay. We've got only about 1 minute here. Oh.
Well, thank you, Dr. Fleck. You did a tremendous job this evening.
You're welcome.
Do we have any questions on the chat or online? No, so thank you, Dr. Fleck. You were exceptional.
You're very welcome.
Thank you for everything that you do. I want to send a special thank you to our University of Michigan, University of Detroit Mercy.
Yeah.
And the leaders here. Thank you for your hospitality. Thank you for welcoming us. We had a great evening together, and I look forward to doing more in the community with your exemplary students. Yeah. And the College of Human Medicine, MSU, thank you all as well. And thank you for joining us.
You're very welcome. Thank you for having me. Thank you for your hospitality. Appreciate that. Good evening, all.
Thank you.
All right.
Thanks.
All right.
Okay.
Great.